Hello everyone, welcome to our live session today. I will be going over a quick startup presentation to welcome you all and introduce you to our program. But first we can go ahead and do our poll, quick little poll to get know how many people we have and what kind of people we have. So you can go ahead and start doing that poll. But in order to introduce you to our program, I'll just be doing this quick startup presentation. PHS is a student-led, minority-led, women-led nonprofit dedicated to helping prospective healthcare professionals gain access to educational resources, no matter their demographic, status, or location. And my name is Muntaha, and I'm the editor-in-chief at Pre-Health Shadowing. Thank you all for attending today, and let's get started. So just a little PSA, we do have our closed captioning for all of our students in our sessions. This setting is available on the bottom of your Zoom screen, and if you need assistance for that, you can definitely direct message one of our team members, and we will help you try to enable the transcript. We are always looking for ways to be more inclusive and ensure our sessions are accessible to everyone. So if you have any recommendations for how we can improve, you can always email us at the email on the screen at info@prehealthshadowing.com. If you want to stay in the loop and follow us on social media, we are active on Instagram and TikTok, and you can sign up for our email list, and this will keep you up to date on when our sessions are, so you can never miss a session. So since this is an international program, I'd like to know where everyone is Zooming from. You can drop your state or country in the chat, and I'm actually calling from Florida. It's wonderful to see so many people around the nation. So we have some wonderful opportunities for you as benefits of being part of the program. If you are looking for research experience and if you dropped the ball on applications this year, I'm just excited to announce that we have a Pre-Health Shadowing research program that will allow students to connect with PIs, which are principal investigators. And they conduct research in a plethora of topics, fields, and locations. This program is 100% remote, which means you have the power to connect with anyone. For more information, please fill out the interest form set in the chat below, and we will get back to you as soon as possible with additional details. We have partnered with Kaplan to get our students a 10% discount code that can be used on all Kaplan products, as well as free resources such as study guides to help you prepare for standardized tests like the MCAT, NCLEX, or PCAT. If you fill out our short survey in the chat, we will get you signed up for free, and these deals will be free once you sign up. So for the month of July, Pre-Health Shadowing is excited to announce that we are hosting a bingo board social event, where you will be able to fill up a bingo board with each board having a specified dollar amount. To participate, all you need to do is post this on your social media platforms and get a group of friends to help you fill up the board. Check out our blog post for more details. Additionally, we have partnered up with Krispy Kreme for you to purchase 1 dozen donuts to enjoy with your loved ones. With a donation of $10, you'll be able to receive your treat while also helping us at PHS. So more information and instructions on how to get your donuts can be found by clicking the link on the chat. Lastly, it is the perfect time to exercise outdoors in the summer with Pre-Health Shadowing's new Pledge Drive event. So for this event, you will be essentially able to work out and also help raise money for an excellent and healthy cause. For every $5 donated to you, you will be required to exercise for 1 hour, and more information on this event and the pledge drive can be found on the link in the chat. And you can definitely visit our website underneath the blog section to find out more. Another partnership that we have is Mask for Mask. It is an amazing women-led organization, and they donate 4 masks for every 4 masks they sell. So all these masks that they donate are going to people in need during the COVID-19 pandemic. You can think of those in the homeless community, healthcare workers without proper PPE, and anyone who's struggling to stay safe. So with our discount code PHS15, you can get 15% off of your order, and PHS gets 10% of the proceeds. So you're also able to donate to a nonprofit that runs solely off the support of our community. If you want to play a bigger role in supporting PHS, we would love for you to join our network of student volunteers and team members. You can apply to be part of our administrative team and lead students in various projects and initiatives with professional outreach and grant writing. So we do understand that as a pre-health student, you might not be able to get the amount of time. So you can definitely volunteer asynchronously with tasks that can be done on your own time whenever you want. So we would love to have you be part of our program, be part of our team, or even as an asynchronous volunteer, and to contribute your own unique perspective. If you're interested in signing up, you can do so in the link in the chat. If you are a high school student and want to get involved, we have started a program called HTP, High School Training for PHS, which allows you to connect with college pre-health programs and get involved in fundraising events for PHS. If you want to go on, you can fill out the application for the high school training in the chat. We want to recognize everyone for the hard work everyone is able to do. And if you're interested in writing about your reflections during our live sessions or just want to write an article about health and medicine, you can definitely submit a blog post using the link in the chat. And you will have your work checked and published on our official website. And this will look great on CVs and resumes. So please take advantage of this and go ahead and write something for our website. Part of our mission at PHS is to promote diversity, and we have an initiative that promotes this by having monthly panels to celebrate different demographics. This is a COVID-19 Roundtable International Student Forum. If you have a mentor or professor or professional that has inspired you, you could contribute to our monthly panels by nominating them using the link in the chat. Also, we humbly ask everyone to donate to our program. Pre-health shadowing is completely student run, and we are trying around the clock to keep this free and accessible to everyone. So unfortunately, because Zoom and our website and our other platforms do cost money to run, we really would like to have some donations. If you are financially able, we request you send this link to someone or you donate yourself so you can continue to support those who can't. Throughout our session today, we encourage you to drop any questions you have for the speaker in the chat, and our team members will be making note of these. If you do want to unmute yourself and ask the questions directly, you can raise your hand during our Q&A session. And I also want to remind everyone to take good notes because there will be a post-shadowing assessment at the end so you can get your shadowing certificate. Lastly, we request that you can turn your cameras on. This is no means an obligation because we are respectful of all of your circumstances, but if you are able to, we'd love to see your faces. And we also request that you make sure to mute yourself, as this will ensure that the professional has all our attention and our complete attention from the audience. So make sure you mute yourself, and if you'd like to, turn your camera on. I appreciate everyone for listening, and I'll go ahead and stop sharing my screen and welcome Dr. Holden, who is professional in emergency medicine.
All right, thank you so much. I appreciate the opportunity. You all are doing a tremendous service to all pre-meds, and I hope that you grow in your endeavors and continue what you're doing, because it really is helping so many students. So I am here today, and I hope you can see my screen. Yes, excellent. So my name is Dr. Lynne Holden. I am a professor of emergency medicine at the Albert Einstein College of Medicine in the Bronx, New York. I did see a couple of New Yorkers here, so thanks for the support and the love. I also serve as vice chair of diversity, equity, and inclusion for the Department of Medicine, and I'm the president of an organization called Mentoring in Medicine Incorporated, and we'll talk a little bit about that too. But today, primarily, I'm here to talk to you about saving lives, emergency medicine. So let's get started. All right, so today I'm going to talk to you a little about, introductions. I know you put some information in the poll in the beginning. I'd love to find out who I'm speaking with. I'll talk a little bit about my path from when I decided I wanted to be a doctor until now. Speak to you, of course, about emergency medicine. And then at the end, we'll go through a couple save a life techniques that you can learn and potentially may have to put into practice. So as far as introductions are concerned, I guess that I'll find out who you are, where you're from, and what educational level you're in. Okay, so we have high school students. Nice. Gap year students. Excellent. A lot of students from the West, some from the Northeast. Okay, all careers. Excellent. Excellent. Well, thank you. Thank you for introducing yourself to me. These are just some of the activities that I am part of. And you'll realize that once you become the pharmacist, once you become the physician, once you become the PA, you will be called to do more and more in your community. And so I urge you to answer that call so that you can help to change lives, not only lives in the hospital setting or in the clinical setting, but lives outside through doing community service, just like volunteering with programs like this. All right, let's talk a little bit about my path. And what you can notice is, first of all, it was not straight. There have been some sharp, almost near misses, and there have been some hills to climb. So it's been an interesting journey. I'm sure most of you have also interesting journeys, but what did you learn from that journey? What did you learn from that hill? What did you learn from that near miss experience? What did you learn from that curve that you took? So my exposure to medicine, besides my pediatrician, came from television. So I used to watch Marcus Welby, MD, Quincy. Marcus Welby, MD was for those of you who don't know, I'm probably dating myself, but he was a physician, had a practice, his own practice, and patients would always walk in with a complaint, but they would walk out with a smile because he was very loving and tender and passionate and compassionate. And I said to myself, you know what? I want to be like that. And so at age 6 is when I decided I wanted to be a doctor. Now, Quincy came along a little bit later, but Quincy, most of you may see reruns of Quincy, but he was a medical examiner. So he basically would solve mysteries. So I decided I wanted to do something in medicine that solved mysteries. So from the age of 6, I pretty much knew that I wanted to do that. My epiphany came, though, when I met some of my mentors. And these are women who look like me, who were essentially changing the world. They were changing Harlem in New York. So we have Dr. Muriel Pettione. She has since passed, but she was known as the mother of medicine in Harlem. So she really came over from Trinidad. There's actually a picture and a tribute to her family at the Statue of Liberty. And so she really was historical and knew many politicians and was very popular and also helped to really change the landscape of medicine in Harlem. Dr. Blaze Thompson, she also was just a joy, a bundle of joy. She passed away, sadly, last year. All of them were in their 90s when they passed away, and most of them still practicing. And then Dr. Freeman, who is at 94 years old and just retired, but she also is very influential in the Harlem scene when it comes to medicine. I will say that during my, I went to undergrad at Howard University. I was born and raised in Philadelphia, went to undergrad at Howard University, and then went to medical school at Temple University. Now it's called the Lewis Katz School of Medicine at Temple. But it was during that time that when I was in undergrad and when I was in high school, that I was able to go to various summer programs. So now, because of the pandemic, they don't have summer programs so much. They are online, just like the research opportunities that were mentioned. But when all is said and done, you should still try to participate in various summer programs, even online, because you'll be able to meet people in your who are along with you, who will eventually be thought leaders and movers and shakers in medicine. Also, you will get to know people at the various institutions who may be able to help you out. So for example, all of these institutions, I met people that I am in touch with now on various committees and various projects. So I encourage you to go to the AAMC website, and they have a program for all health careers, for students who have finished their first and second year of college. It's called SH Prep, and I encourage you to please sign up for that program because it really does give you a jump start when it comes to health careers. Let me talk to you a little bit about the journey because I think a lot of people may not understand the journey. And it's important for you to know the journey because you have to know for yourself planning for your family, but also you have to keep your eye on the prize. So for example, I went to high school 4 years, college, I spent 4 years in college. I did not take a gap year, but students now are taking gap years. And I will tell you from sitting on the admissions committee for 15 years of the Albert Einstein College of Medicine, that gap years are very favorably looked at so that you can gain more experience and grow in your medical experiences and also meet various people and, you know, study for the MCAT. So, and some students have to actually do some additional coursework through a master's program or a post-bac program. That is after college. Then medical school, if you choose to go to medical school, is 4 years. After that, you become a doctor, but then you have to decide what sort of doctor you are going to be. That's when you apply for residency programs. Usually you do that in the beginning of your 4th year of medical school or the end of your 3rd year. Residency programs are in all sorts of specialties. Some residency programs, such as internal medicine and pediatrics, maybe 3 years. Residency program in emergency medicine is 4 years. As you get more specialized, so for example, orthopedic surgery is 5 years, cardiothoracic surgery, maybe 6 or 7 years. There's usually research embedded in that learning experience. After residency, one has an option to complete a fellowship. That fellowship may be giving one more experience in their actual specialty. So for example, if you decide you want to be a pediatrician, you want to be a physician for children, you may then decide that you want to specialize in learning all about the heart and treating patients who have heart disease, in which case you would do a fellowship in cardiology and you would learn about the hearts of children and all the diseases. Now, if, for example, you wanted to be a surgeon, you would have to do pediatric cardiology surgeon. You would have to do 5 years of surgery and then pediatrics fellowship and then a cardiology fellowship. So you understand how the more specialized you get, the more time you will spend in these apprenticeship programs, the residency program and the fellowship program. You are getting paid, so don't fret about that. And as you go up and move on and get more advanced, your pay increases. However, you will not get paid at the rate you will once you become certified. So let's talk about that. So this slide just gives you an example of all the standardized tests that are utilized and needed to be passed to get to the next level. Hold on, don't panic. You've all passed the SAT, except for our high schoolers, which I'm sure they'll do fine. So as long as you have your strategy down pat, so when I say that, how do you learn best? There's something called a VARK survey, V as in Victor, A, RK.com, VARK.com. I encourage you all to go there and to find out what is your main mode of learning. All of us have a mixed modal learning. We learn in different ways, but what is your main way of learning? And how can that actually be enhanced? You can take a free survey, takes about 15 minutes, and you will learn what your main mode of learning is, and you'll learn about all the other different ways of learning. V for the visual learners, A for the auditory learners, R for the readers, and K for the kinesthetic learners. So those people who have to run or do whatever to get the information in. So I encourage you to please make sure to visit vark.com. So getting back to the test, once you figure out your strategy for learning and you actually as you go through your classwork and your coursework, you should be practicing sample questions so that you learn the language of these tests. So for example, to get from college To medical school, you have to take the medical college admissions test. To go from college to pharmacy, you have to take tests for pharmacy, pre-pharmacy schools. For PA, you have to take the GRE. So there are always some standardized tests so that an admissions committee can analyze and assess how much you know compared to someone else. Because we're all coming from different institutions and we're not sure what the institutions are actually teaching, the rigor, etc. But the standardized tests will help to assess that. To get from medical school, for example, to residency, you have to take a 3-part national board exam. That board exam, parts of it are pass-fail, but don't be fooled, because even though it says pass-fail, doesn't mean that it's easier. It may be in essence harder. So make sure that you practice and prepare for all of these tests. But hold up, it doesn't stop after you finish your residency. No, you have to take a certification exam. So you have to prove to everyone that you actually learned something during that 3 to 8 year of apprenticeship that you did. And in addition to that, that test could be a 2-parter, meaning it could be a computerized or used to be written test, and it could be an oral exam where you're sitting in front of someone or one-on-one virtually, and they're asking you questions. So you have to answer questions to their liking in order to pass the exam. Remember, there are tools to study for these exams. Don't wait to the last minute. Make sure you're learning these tools and tips as you go along. And finally, after you're in practice, guess what? You still have to take some exams because they want to make sure those governing bodies, American Board of, they want to make sure that you understand and you have kept up with your reading. And I'm telling you, if you don't like to read, if you don't like to study, if you're not a lifelong learner, this is not the career for you. So you must love to read. You must be intellectually curious in order to undergo any of these health professional careers. Along with that, you have to have a high level of social and emotional intelligence because you are dealing with people often under duress. So I recommend a book called How to Win Friends and Influence People by Dale Carnegie that everyone should read. How to Win Friends and Influence People. It's really a roadmap on how to build your social and emotional intelligence. So there's more. After I had been practicing emergency medicine for 10 years, well, not 10 years, maybe about 4 years, and had my daughter. I had my daughter 1 week, and a week later, I was in the hospital because I had something called postpartum cardiomyopathy. So it's real. Diseases and morbidity and mortality, illness and death in young mothers who are pregnant or have just delivered. It's a problem, and it's especially a problem among minority populations. I actually had something that was very rare, again, postpartum cardiomyopathy. And fortunately, it was detected early, 1 week after I delivered. And also, I was able to get on appropriate medications. I was fortunate. Many, many women who have this disease die because it is not diagnosed, it is underdiagnosed, or they may need a heart transplant in order to return to normal functioning. Or they may be kind of stuck where they have issues with their heart so that they're unable to perform at their age. So for example, they may have the heart of an 80-year-old instead of a 34-year-old because of the damage that has been done because the heart gets enlarged as a result of the hormones of pregnancy. Well, while I was home, I had to figure out I cannot stay still. So my husband said to me, you know what, there's so many students who want to be a health professional, but they just don't know how to do it. That's when Mentoring in Medicine was started. It is a 501c nonprofit. It's headquartered in the Bronx, but we're actually a national organization. We work with students from elementary school through career. And our specialty is really helping those students who are borderline, those students who have been told no, those students who have been discouraged. And our job is to help them not only to play a different movie, but also to gain academic enrichment, leadership development, community engagement. We work with their families and also provide them with mentors. And guess what? We've also been pushing this platform. So we're very happy to be part of this platform. And here's some of our activities. You can see how we push into schools. We also have community service activities. Right now, for example, we're doing a COVID-19 impact education and empowerment seminar. We have about 500 students participating in that. This is our second iteration of that, and that's an international effort in partnership with 6 medical schools in New York. We also have a medical school preparatory boot camp. We have internships in the Bronx and in New York, and we have a program called the Teaching Fellows Program. Some of our outcomes you can see here. We've touched about 55,000 students, parents, and educators. And also we have about a 92% acceptance rate of students who come out of our boot camp who apply to medical school. All right, let's get busy. So now we're going to talk about emergency medicine. Can you tell I really love it? It's great. So I hope that some of you will be encouraged to pursue emergency medicine somewhere down the line. So in emergency medicine, our job is to solve the mystery. How do we do that? Well, we take a history from the patient. We do a physical examination. We have to form a preliminary, what we call differential diagnosis, or what on earth could be wrong with this patient? And we have to get supporting data to actually rule in or rule out different disease entities. It's very urgent in some cases. Sometimes the patient cannot speak for themselves. A lot of times, well, every time we look at the vital signs. So you see the vital signs listed there, the temperature, the blood pressure, the patient's heart rate, respiratory rate, their pulse oximetry, and their pain scale. And we always take into account initially the patient's vital signs, their complaint, of course, and we always do our ABCs. So we want to make sure that patients have a patent or open airway, that they are actually breathing, and that they are getting in oxygen and able to exchange that oxygen and carbon dioxide, that they're not bleeding anywhere that we can see, or internally that we cannot see, and of course that they have all their faculties and they're not disabled or showing any signs of a stroke. So we're going to do a little poll, and I think I can get a little help with this. So we're just going to you tell me if these vital signs are normal or not. So for number 1, maybe you can type into the chat. Do you think that a temperature of 100.4 Fahrenheit is normal, degrees Fahrenheit is normal?
Okay, so we have a lot of answers coming in the chat, and everyone is saying no.
Excellent, excellent. So that is considered a fever. Okay, there are many ways to get a temperature. Well, there are a couple ways. You can get the temperature by someone's mouth, but of course, if someone does not have their mouth and if the probe is not under their tongue properly, you're not going to get an accurate temperature. If they just drank a cup of coffee, you're not going to get an accurate temperature. If they just had a cold smoothie, you're not going to get an accurate temperature. The only way to really get an accurate temperature is a core temperature. And that is where we put a probe into the person's rectum to get a core temperature. That's the only way to get an accurate temperature. So while you see temperatures going across the thermometer, probes going across the forehead or being stuck in the ears, that can give us an idea, but clearly a core temperature is the most accurate. What about number 3? What about number 3? Is a heart rate of 56 normal?
So once again, I can see in the chat that everyone is saying also no.
Exactly. So a normal heart rate is between 60 and 100. So if it's below 60 or above 100, or even hugging the borders of 60 to 100, we get concerned. Okay, so clearly number 4, above 100, yes, that is also abnormal. All right, what about a respiratory rate, number 6, of 14? Is that normal or not? Yes or no? Okay, any verdict?
Yeah, we're getting it's getting a little more confusing now because we're going to respiratory rate, but we do have a few yeses for 6.
Okay, so normal respiratory rate is between 12 and 18. So bravo. Yes, you're correct. That is normal. All right, and for blood pressure is number 7, a blood pressure of 175/100 normal.
Okay, so we have a lot of no's, and someone even mentioned out that it's probably hypertension.
All right, so certainly that blood pressure is not normal. Normal blood pressure is 120/80. And what about a blood pressure of 95/60? Is that normal?
For this one, we're also getting no, it's not normal.
Okay, so it is not normal. Now, some people do have, if they're petite, meaning they're very thin, or if they are, their blood pressure may run a little on the low side. As long as they're mentating and they're not feeling dizzy or weak, then that is their normal blood pressure. Alternatively, someone who works out a lot and they're very athletic, their normal heart rate may be below 60. So always we compare what the patient comes into, if we have the benefit of having any old data, to that data about them. Everyone is different, and we have to take into account their, what we call their protoplasm, what their body is like, also what medications they're taking, and any medications they may have ingested, and also their complaint. So I mentioned that we take a history. 90% of the diagnosis comes from the history. That's why you have to practice listening skills, because the patient may tell you some information, they may not tell you some information. So you really have to be able to probe and to find out the chief complaint, why the patient came today, there, right now. How did they came in complaining, for example, of abdominal pain? When did the abdominal pain start? Where is the abdominal pain? Where does it go? What else happens with the abdominal pain? So you get the picture. We have to ask a lot of questions. And sometimes patients don't like that because they have to tell the same story over and over again. But inevitably, one person will get one story and another person will get a slightly different story. So it's important to be able to talk to the patient directly to get their information. We, of course, want to know their past medical history, their past surgical history. If they've had any psychiatric history, we want to know medications and drugs, even over-the-counter medications or supplements they may be taking. We want to know their last menstrual period and a pregnancy history in a fertile female. And we have to do what's called a review of systems. So that means a head-to-toe review. Now, if a person comes in because they cut their finger, we're not going to, do a whole review of systems on them, but we want to do what's called a pertinent review of systems to find out if they have any other clues in their history that could be helpful to us in making a diagnosis. Also, we have to examine the patient. So we examine all pertinent body systems. First, we look at them, which means that if a person has on clothes, we disrobe them. Now we disrobe them. We make sure we have a chaperone in the room with us so that they can also assist us and also observe what we're doing. We want to auscultate or listen to the various organs that we can, the lungs, the heart, the abdomen, the blood vessels, for example, in the neck. You may be able to hear what's called a bruit, which is sort of like a blowing sound that can tell you there may be a blockage there. Also in the femoral region, you may be able to hear a similar sound. So it's important to have an instrument, a stethoscope, which is here in my background, which really is a great instrument to have, and a necessary instrument to have in the emergency department. Percuss, we feel, and we listen to the sounds that, for example, the abdomen makes or the lung makes. That can tell us, if we percuss, if a person has a effusion or fluid on their lung that may be causing, for example, their shortness of breath. So that's very important. Or in the abdomen, we can percuss, and that's basically where we take our finger, and I don't know if you can see it or not, but if we knock our finger against their skin and we just listen to the sounds that we get. If a person, for example, has a liver problem, they may have ascites or fluid in the abdomen, and we would be able to percuss or listen to where that fluid is by how much they have through percussion. Also, palpation is very important. So not only do we have to observe, we have to listen, in some areas percuss, but we have to feel if something may be abnormal. Maybe a person is complaining of hair loss or fatigue, and maybe their thyroid is a little large. So we have to palpate their neck and see if we can palpate any nodes in their thyroid or if the thyroid is enlarged. Additionally, we have to palpate almost every organ of the body, again, that's pertinent to the patient's complaint. We note significant findings, and then in some cases, such as a neurological exam, we may need extra tools, such as a reflex hammer, to help us, for example, if we're concerned that a person has a stroke, we want to make sure that they're responsive and that they have different reflexes, that their reflexes are intact. Again, head to toe, including the skin, the genitalia in some cases, and also the rectum in some cases, depending on the patient's complaint. We also have tools to help us. Some of those tools are blood tests. You may see on television where there are different colors, different colored tops, and we use those different colored tops for different blood tests. So for example, a purple top helps us to find out what a patient's blood count, red blood cell, white blood cell platelets are, and it has a certain liquid in it called EDTA, so that the blood does not clot once we get it out of the person's arm. For example, if a patient, we want to see if they clot, how their clotting is, we check their platelets, yes, but we also check their PT, pro-time and prothrombin time, and we do that using coagulation studies or a blue top tube that has 3.2% sodium citrate, so that the blood does not also clot, and that facilitates that test. But fortunately, we have what's called point of care testing, meaning if a patient comes in with a complaint and we're concerned about them, we can get certain tests right there on the spot. Some of those include a glucose. So if a person comes in and they maybe are not thinking properly, we can check to make sure that their glucose is not too high or too low. Another may be, for example, a young lady who has severe abdominal pain, maybe with unstable vital signs. So their blood pressure, heart rate, respiratory rate are too high or too low. We can do a pregnancy test right on the spot using their urine to check and see if they're pregnant, because that could mean that they have what's called an ectopic pregnancy or ruptured tube from the pregnancy and could be bleeding internally that we cannot see. So you get the point of how we use these rapid point of care tests in the emergency department. We now even have a point of care COVID test that we use in the emergency department for patients who may be going to the operating room or some emergent procedure. And we want to make sure to let the team know who will be taking care of them if they do or do not have COVID. We also have other instruments in our toolkit. We have an X-ray plain film. We can get X-rays that will help us to see mostly bones, but also if there is air where there should not be in some of the orifices. We also have the CAT scan and the MRI machines. So the CAT scan is really shaped like a donut, kind of like your Krispy Kreme donut that you are advertising. So it's really pretty narrow, and a person lies on the stretcher and it just goes in and out for whatever part of the body we'd like to investigate. The MRI is a little bit more daunting for a lot of people because this is actually a newer MRI, but it really is like a tomb and people really don't like it. They get very claustrophobic in it. And there are very few open MRIs and they are backed up for a long time. So oftentimes when a patient gets an MRI, we have to sedate them or give them some medication so that they're a little drowsy and can get through the test, a short-acting medication to help them get through the test. Now, the CAT scan and the MRI look for different image different aspects and give us information. So it depends on what the patient's complaint is. For example, if the patient comes in and they're complaining of abdominal pain, we would most likely get, if warranted by their blood tests and their vital signs, for example, if they come in with right lower quadrant abdominal pain, the right side, we're worried about their appendix that lives in the right side of the abdomen, we would get a CAT scan of their abdomen. That would allow us to see all the organs in the abdominal cavity and to see if there's a problem with any of those organs, the gallbladder, the pancreas, the appendix, the intestine, the kidneys even, and to make a decision about what we will do. Now, there are many variations. The person can drink contrast, they can get contrast through the IV, they can get one or the other or both. So we really decide which type of CAT scan we want to get after we find out what it is could be going on with the patient. Patients come in with changes in their mental status or paralysis. We do a quick CAT scan. We want to know if there's any evidence of a stroke. And if there is, what type of stroke is it? And what sort of next step will they need? What sort of intervention will they need? And we call in the specialist to come down and to take those people, examine them, and then take them, if they qualify, up for certain emergent testing. The MRI, on the other hand, helps in stroke. Yes, it can help delineate and look at the brain more, but it also helps when it comes especially to bony injuries. So for example, if someone was in a car accident and they were complaining of neck pain, maybe their neck jerked back and forth, and they had some neurological changes, we would try to get an MRI quickly to see if there was any damage to the tissues of the neck. You may hear of people who have knee pain. I just read where a bride was dancing and she dislocated her knee. Well, she would certainly need an X-ray and for immediate treatment so that she does not have any impingement upon the nerves and the blood vessels that are in the posterior aspect of the knee. But eventually she will also need an MRI to look at the ligaments and tendons to make sure that those were not damaged in the knee. So as you can see, we utilize our toolkit, the tools in our toolkit, depending on our patient and their presentation. After we get the supporting data, which I just discussed, we then go into the clinical progression. So we monitor the patient. We don't just take vital signs one time. We repeat them often so we can notice the change in vital signs. We examine, re-examine, and re-examine the patient because oftentimes the exam changes. And then we incorporate all of our findings from the lab test, well, from our history, our physical, the lab test, the radiographical test, and we try to make a decision as to what is going on with the patient, and then if they can in fact go home. So generally, patients in the emergency department, they go home with follow-up, or they're admitted to the hospital for further care, or they may need an emergency intervention, and sometimes they don't make it. So we are very cognizant of all of these, and our job is to find out what can potentially kill that person right then and there, and how can we figure out what that is and stop the course of that and save their life. All right, so let's have a little fun here. You are emergency medicine physicians. Your patient says, "Help, I'm having chest pain." You look at the patient, you determine that their airway is patent, they're breathing, they're not bleeding that you can see or you suspect, and that they are thinking properly, moving all their extremities. You're not concerned about a stroke. You look at their vital signs, okay? Their vital signs are stable. You take a history, you do a physical, you get the data. So what in the chest, what lives in the chest? And I guess you can type this in the chat because it's a sort of open-ended question that could potentially be wrong with this patient. What lives in the chest? All right, I see the chat's going up. The heart, yes, the heart and lungs, excellent. Excellent. Anything besides the diaphragm, excellent. Anything besides the heart, the lung, the ribs, excellent. Well, the gallbladder, Edwards, in the abdomen, but you bring up an interesting point because the patient can present with abdominal pain because the gallbladder is up against the diaphragm. So that is an interesting point, but the gallbladder is in the abdominal cavity. The vena cava, yes, so the aorta, the great vessels, the aorta and the inferior vena cava are also in the chest. Excellent, everyone, excellent. So you know your anatomy. So remember, when we talk about the chest, a person comes in with chest pain, but we have to remember that there are many organs in the chest that could be causing the pain. You mentioned the heart, the lungs, you mentioned the blood vessels we talked about. Someone mentioned the diaphragm, okay, the ribs. There's also the esophagus that sits behind the trachea, okay? And so there are many different aspects that we have to worry about. There's muscle between the ribs that could be causing pain, right? There's also skin. So someone could have a rash on their chest and they could have chest pain. So we have to entertain all of these diagnoses and rule in or out anything that could be wrong with them. So, for example, this patient has what we call zoster or herpes shingles or herpes zoster. You can see here that they could very well have chest pain on the left side of their chest. Well, guess what? Someone could also be complaining of chest pain on the left side of their chest if they're having a heart attack, okay? And minorities and females do not present in typical ways. They present atypically. So for example, instead of having the classic Levine sign where they're clutching their chest, they may have a little anxiety or impending doom, a sense of impending doom, or a gassy feeling, or a strange feeling under their breast, or jaw pain, or arm numbness. So you get the picture that people present differently for very serious diseases. So for example, in this picture, what's happening is that the blood vessel, the coronary artery that feeds this part of the heart, okay, this coronary artery that feeds this part of the left ventricle is blocked. And blood cannot pass it. And therefore, nutrients and oxygen cannot be exchanged, and this part of the heart is damaged, okay? This person, if they were having a certain type of heart attack, if their EKG or electrocardiogram demonstrated what we call an ST elevation myocardial infarction, STEMI, then they would go straight to the cath lab at our hospital and get what's called a cardiac catheterization if they were stable, their vital signs were stable, which means that they would get a long tube put into their femoral vessels. They would get a certain dye, which would allow the interventional cardiologist to see where the blockage is and to be able to put a stent in to alleviate the blockage and also to give them local clot busters to break up the blockage. So they're very sophisticated treatments that people can get. But the emergency department, we are the ones that really are the gateway to the patients getting those treatments. All right, so here's case number 1. You receive notification, you're on duty. You receive notification that in 3 minutes, ETA, estimated time of arrival, you will be getting a 32-year-old female who the EMS workers suspect is having an allergic reaction. These are her vital signs. So is her temperature normal? Yes or no at 98.7 degrees Fahrenheit?
So we do have people in the chat saying yes.
Yes, excellent. What about her heart rate at 99? Is that normal?
Okay, mostly we do get a yes.
Okay, she's normal, but she's high normal. Remember, 100 is our cutoff. What about a respiratory rate of 32?
Oh, for that one is a no.
All right. Yes, you got it. Yes, it's not normal. It's abnormal. Okay. What about a blood pressure of 145/88?
For that one is also not normal.
Okay. And what about a pulse ox of 93%?
Also no, typically on the lower side.
Exactly. So 98 to 100% is normal. And she does not have any pain. So you and your team are waiting for her. And this is your patient. All right. So are you worried about this patient? Yes or no?
Mostly everyone says yes. Very worried.
Yes, I agree. Very worried. So from the door, I was very worried about this patient. And then I introduced myself and I said, hello, my name is Dr. Holden. Her response was, So that told me that the swelling we're seeing here with her lips is actually, and under her chin, actually is affecting her epiglottis, her vocal cords, and the entrance to her windpipe or her trachea, and then she was having big problems. So immediately we had the team to, we didn't know what was causing this issue, but we knew that A was out of whack. So we had to take care of that before we could do anything. So we essentially intubated her, which was to put a tube into her mouth, into her larynx and trachea, and help put her on the machine so the machine could breathe with her, for her, and maintain her, that tube would maintain her airway while we treated her, while we got a history to find out what on earth happened, and we were able to treat her. So it ended up that she was at her 40th birthday party, and it was a potluck with many people, and she had been tasting a little of this and a little of that, and a little of this and a little of that, and she was allergic to shellfish. And some of the dishes had shellfish. One had shellfish in it, and as soon as she had it, she swallowed it, she noticed that her throat became very itchy, and that her tongue started to swell, her lips, her eyes, etc. And the people at the party called 911. They picked her up and brought her straight, she and also her guests, straight to the hospital, to the emergency department. When she got there, again, we intubated her, but we were also able, the team, so things happened simultaneously. So it's hard to say A, do this, B, did, but basically everyone kind of swooped down on her, and we were able to establish a couple of IVs, give her medications to help fight that allergic reaction, and to, again, maintain her airway. That was our first priority, and to make sure she had gas exchange. And she went up to the intensive care unit. 3 days later, I was called to the front desk, and this young lady introduced herself and said, "Oh, Dr. Holden, do you remember me?" And I said, "No, I don't remember you." And she said, "Oh, all I can remember was that you had a plastic tube in your hand. That's the only thing. You told me that I was going to be fine. So I just wanted to let you know that I am fine and I'm going home." And I was like, wow, she looked totally different. And she bought me a little Snoopy doll that I have in my office to remember her by. But, you know, it's those times when really she was on the brink of death. Had she not gotten to the hospital when she did, and had we not been ready for her, she probably would not have made it. What was happening to her? Well, she was having an anaphylactic reaction, okay? Everything short of abnormal vital signs she had. So she had tongue swelling, she had swelling, which caused swelling. She had swelling of the lips, the tongue, and here where we have the epiglottis, that is the keeper and the garter of the trachea, was also swollen. Here you have the esophagus. So just be mindful when you, after you eat, and if you're laughing and eating, the epiglottis opens, and that's how food goes down into the wrong, when they say it goes down into the windpipe and you start choking. Well, that's how it happens, because when you're not supposed to talk and eat at the same time, and certainly not laugh and eat at the same time. Here the epiglottis guards it, and if it becomes very swollen, you can see that it would block off that area. The trachea, the person would not be able to have their have exchange of air. So that was what was happening with her. She was saved. She actually did well. But for everyone who does have allergies, just be mindful of taking your EpiPen, your Benadryl with you. It is here in the Northeast, the summertime, there are wasps out there, there are bees, and a lot of people are allergic to that. So please make sure that you take your medication with you. It may not be cool when you're with your friends, but it can save your life until you can get to a hospital. Case number 2. All right, how are we doing with time? Pretty good. All right, so we have a 68-year-old male, history of smoking tobacco. These days, you have to ask patients what they smoke, okay, because that can make a difference in their treatment. Complaining of shortness of breath. He arrived by car, and his daughter also noted 1 week of cough. His temperature 100.2, by mouth, abnormal, we're concerned. Heart rate 125, too high, we're concerned. Blood pressure 90/60, too low, we're concerned. Heart rate of 40, respiratory rate of 40, too high, we're concerned. And pulse ox of 88%, also too low, we're concerned. These vital signs are alarming, okay? They are off track. They're all abnormal, so we're concerned. Pain scale of 9, we like to see 0, of course. 10 is severe pain, so he's having some pain too. So right away, we know this patient is in trouble. We look at him and we see that he is in trouble. He is assuming the position, we call it the tripod position. That's someone who is having problems breathing. His mouth is open. He's bracing himself. He's leaning forward to try to get in as much air as possible. So from across the room, you can see that this person is breathing. And I can empathize with him because the night before I went to the hospital with the postpartum cardiomyopathy and the congestive heart failure, I looked like this on the toilet all night before I, ding, ding, realized that there could be a problem with me and went to the hospital. So this position is real. So we talked about that tripod. Well, let's talk about what could be wrong with them. Ooh, let's go back. So we know he has problems breathing, okay? We see here the tripod position, the person leaning forward. So he's a smoker, okay? He's had a cough. So type into the chat what you think could be wrong with him. What should we be worried about? Asthma, pneumonia, pleurisy, yes, great, 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 all of the above. Increased fluid, yes, he could have that also. Excellent, excellent. So he is, thank you, Tyler, maintaining his airway, but his breathing is not normal. So we have to do something about that. So that patient, let me tell you what's happening with him. He basically has, as you can see here, the trachea, the lung, their bronchioles, and alveoli. The gas exchange, carbon dioxide for oxygen, occurs in the alveoli. Here we have a healthy bronchiole and alveoli. So we see here that gas exchange can occur through this thin membrane in the alveoli. The bronchiole is patent, so you can get good air exchange, good air movement through this open area. In someone, for example, that has pneumonia, however, the walls of the bronchiole are inflamed from not only the reaction to infection, but also they have pus that's also blocking the tube, so there's not good air exchange. They also may have excess mucus and fluid in the alveoli, so that thin membrane becomes thicker because there's fluid there that's blocking the air exchange. So that person has problems breathing, a low pulse ox, they're in respiratory distress if it is too widespread. Here on the right side, you see that there are 3 lobes to the lung. On the left side, there are 2. So here's a chest X-ray of this patient's chest X-ray. What do we notice? We notice that in the normal chest X-ray that we see that he has good lung fields. So when we read a chest X-ray, we usually start, different people have different ways to read it, but the important thing is that whatever way you read a chest X-ray, you are able to see get all the information that the patient paid for, basically. So you want to make sure you get all the information you can from an X-ray. So for example, in the normal X-ray, we can see if we start in the middle, we see the trachea, we see that it bifurcates or it splits. Remember there, hold on one second. Previous, okay. So we see here the trachea bifurcates or splits so that air can go to through the bronchi into the bronchioles and the alveolar, as we just saw in the picture beforehand, to the different various lung lobes. We see here that can't quite see it, but you can see that the esophagus also has air in it, so it's coming down to the stomach, and it ends up, you can see the bubble, the stomach bubble here, so you have fluid and gas there. You can see that there are blood vessels, the aorta, this is the aortic knob. So if this was out here, for example, we would be able to tell that there's a problem, maybe an enlargement of the aorta. So you can follow the aorta down. Also, you can see the heart. Okay, so you see the borders of the heart here. All right, as you move down, you can also see the diaphragm. So it's easy to see how if there's something against the diaphragm, it can very well be mistaken for chest pain because the diaphragm would be irritated. If someone has hiccups, for example, and the hiccups have lasted longer than 3 days, it tells we know that there's a problem, and they may have something that is in fact tickling the diaphragm or irritating the diaphragm. Then you go onto the bones, so you can see here the ribs. We can't see the muscles. You can also see the clavicles. You can see the scapula, the head of the humerus. So you do get a lot of information. This is a normal chest X-ray. This is an abnormal chest X-ray. What are we seeing here? We are seeing inflammation, evidence of inflammation. So we see here that he has a multi-lobar pneumonia, both on the right side and on the left side. We're not able to see the heart border. We're not able to see clearly the border of the diaphragm. We know that's a problem. So this patient has pneumonia. Ladies, how much longer do I have?
There's like roughly 30 minutes, but you're more than free just to like go over a little bit. It's fine.
Okay. All right. So let's talk about what's happening now. Guess what? This is the X-ray of someone who has COVID pneumonia. So you can see how devastating COVID is to the lung and why it is so severe, because these areas of inflammation are actually fluid and liquefaction of the lung tissue that scars, and the person cannot get this lung tissue function back without great rehab and prayer, really. So you can see why COVID is so devastating and why we are concerned about those who present with COVID. So again, COVID pneumonia is usually diffuse. This is, of course, a severe case, but people can have mild cases and still present very ill. All right, let's talk a little bit about COVID, just a few minutes, because it's all around us and it's coming back with a vengeance. Never left, but you know, it's really resurging in different forms. So I think this is going to be the new normal. I think we're going to have to get used to COVID, mask wearing, and vaccination, and incorporate it into our history when we evaluate our patients. So COVID is a virus. These spike proteins are the ones that are the culprits. They latch on to what we call ACE2 receptors. Those receptors live all over the body, but especially in the lung, especially in the intestine, in males, in the testicles. So those ACE2 receptors are all over the body, but where they are especially is where these spike proteins latch onto. This spike protein is also what was used to make the vaccines, the mRNA vaccines, and also the Johnson & Johnson vaccines. But the vaccines were made against the original spike protein. Since then, we've had quite a few mutations in this spike protein, which is why there is a concern about the vaccines, maybe some of them not being as efficacious because they target the spike protein. Yes, there is cross-reactivity, meaning that there is some protection, but we're finding that there's not as much protection as we originally thought. But it is still highly recommended that one gets the vaccine to protect them from severe COVID illness. So what is COVID? It is a novel or new virus. It is thought to have jumped. There are many theories about where it came from, but clearly it came from an animal to a human and is a respiratory virus. We have been in a pandemic since March of 2020. We have learned a lot. When I said you have to be a lifelong learner, no more is that evident than it has been over the past year-ish, because it is in that time that I think it's been now 72 weeks that we have learned about, we have gone from zero to where we are now learning about this disease. We know that it spreads 3 ways, primarily through respiratory droplets. And that is when someone coughs or sneezes. This is an electron microscope picture. So we can't see this, but this is what's happening. So if someone sneezes, not only do the virus particles and bacteria get propelled up to 6 feet, but also they fall as they go. So the person has contaminated not only the air around them, but also whatever is around them, the table, the door, the floor, etc. So we also know that COVID lives on it's a fomite. It lives on innate or objects that are not live. So for example, if someone coughs and they have COVID and they then touch the elevator button, and then you come behind them and you touch the elevator button, and then you touch your mouth, nose, or eyes, because the virus gets in through mucous membranes, then you could very well be contaminated with the virus. If you do not have the vaccine, it may affect you severely. If you do have the vaccine, it may affect you, but hopefully not as severely. So that's a fomite. It also is spread through the GI tract. So if someone in your house has COVID and they have a bowel movement, okay, they flush the toilet and all of those virus particles spew up into the air. You come in after them and you go to the bathroom or use the bathroom, then you notice, then if you're inhaling, you could be inhaling some of the virus particles, okay? So that's why it's advised that after one uses the bathroom, they close the lid if they can, so that they keep those particles contained in the toilet itself. So they use the bathroom, close the lid, flush the toilet, so those particles, those virus particles, don't spew out into the air. So again, it's spread through someone coughing or talking even. If you touch something, a fomite, and then you touch your own nose, mouth, or eyes, and then of course having close contact with someone, which is why we recommend the 6 feet. We have the 6 feet physical distancing rule. Just to compare it to the flu, just know that it is much more contagious than the flu. The number of days of contagion ranges between 2 and 14. The flu is only 1 to 4 days. And there have been far more people getting hospitalized this year from COVID than the flu. It's essentially like the flu's disappeared, honestly. We haven't seen too much flu, probably because of the mask wearing, but we have seen the COVID. COVID is an interesting, tragic, fascinating disease. Number one, it affects everything essentially from head to toe, not only during the short term, but also there are long haulers. So people who had COVID who are still suffering from symptoms of COVID, even though they don't have COVID in their system. So in the short term, we know that it can cause strokes. It causes clotting in the blood. Those clots can go anywhere. They can go in the brain, they can go in the lungs, they can go in the heart, kidneys. So that is one of the very deadly consequences of COVID. They can cause, as I mentioned, strokes. It can also cause confusion because it does cross the blood-brain barrier. So people can present with encephalitis or swelling of the brain and confusion. It can affect the heart, not only with heart attacks, but affecting the lining or the pericardium of the heart and the myocardium or the muscle of the heart. So it affects the heart in different ways. The lungs, we know it affects, as we showed, the pneumonia, but it can also cause blood clots that go to the lung. With kidneys, it can cause kidney failure. Many patients require dialysis. And in the intestine, it can cause profuse, severe diarrhea. It can cause rashes on the skin. And the pancreas, as long-term, can be affected. And quite a few patients who did not have diabetes before are developing diabetes after having COVID. And we all know that it can cause a loss of taste and smell. At least the original variant can. The Delta variant doesn't cause that as prominently and has different symptoms, but we have to be aware of these symptoms. And that's why reading is important, because what we read, what we learn as emergency physicians, we use every single solitary day to take care of our patients. The other reason why COVID is tragic is because it has really unearthed and uncovered what we know as health disparities or inadequacies and inequalities in care for people who are underserved. So for example, people who suffer from cancer, obesity, diabetes, disproportionately in minority communities have been disproportionately affected by COVID because COVID preys on people who do not have a strong immune system. Also, we know that in the beginning and now if someone has COVID, they're asked to go into isolation. Well, if you live in a 2 or 1 bedroom apartment with multiple family members, if you're in a multi-generational home, there's nowhere to go. So you have to really try to find out how you're going to, quote unquote, isolate yourself from others so that they also do not get sick. Also, we find that many underrepresented minorities are in frontline jobs. So they drive buses, they work in environmental services, they are in restaurants, okay? They are in healthcare. So they have to be encountering, in order to survive, they have to go to work. And so they have to encounter all folks, all people who could potentially have COVID. So COVID is, like I said, it's something like we've never seen before. And unfortunately, it is not yet gone. So be safe and be aware. The symptoms you see here, certainly, once you have shortness of breath or difficulty breathing, it's a bit too late, but we want to make sure to get the word out that now we have different medications in the emergency department that can help to decrease the incidence of these severe illnesses. So for example, it's not at every hospital, but at most academic centers, they have monoclonal antibody. So you might have remembered that our President Trump, when he got sick, got monoclonal antibody. At that time, it was an emergency use authorization, meaning that only certain people could get it. Well, now a lot of academic hospitals in the United States are giving monoclonal antibody in the emergency department so that our patients do not develop worsening COVID symptoms. Again, if you feel that something is not right, that you have COVID, a family member has COVID, urge them to go to the emergency department because there may be treatment to help decrease the symptoms and to help prevent them from getting worse from COVID. Other symptoms include persistent pain or pressure in the chest, new confusion, inability to stay awake, or blue lips. And by that time, it's a bit too late, blue lips. So how can you protect yourself against COVID? Can you type into the chat different ways you can protect yourself against COVID? Wearing masks. Thank you, Ghana. All right. Thank you for the poll. All right. So how can you protect yourself against COVID? Excellent. All of the above. Yes. So first of all, you want to make sure that you have reliable information. Okay. Something that is .gov, for example, is reliable information. The CDC.gov, your local health department, reliable information. You don't want to get information that is hearsay, that's not reliable, okay? So reliable information is very important. You want to be able to control those underlying diseases that you or your family members or your friends may have, because again, COVID can be very severe in people who have underlying diseases. You want to boost your immune system by eating healthy foods, incorporating vitamin C and vitamin D into your diet, by exercising, by resting, okay, getting enough sleep, and by practicing mental wellness and stress reduction. Because if you are very anxious, then your chances are that your immune system is going haywire, and you have to be able to try to boost your immune system in many different ways. Get vaccinated. It is now being shown with this Delta variant that patients who are vaccinated versus those who are not vaccinated, patients who are not vaccinated are presenting with more severe disease, being hospitalized, and also even severity and increased deaths. So please talk about vaccination, research it, but it is important to know that those who are vaccinated are the ones who are not getting severe disease. I'm not saying they're not going to get a disease, but they're not getting the severe disease where we saw patients being hospitalized and dying in great numbers. Make sure you wash your hands often. Use soap and water for 20 seconds, happy birthday ×2, or hand sanitizer covering your entire hand that has at least 60% alcohol. Very important. Often washing your hands. Make sure you cover your mouth and your nose when around others, and also consider wearing goggles to protect your eyes. Remember, I said that COVID can get in the virus through mucous membranes, your mouth your nose, and your eyes. Do not touch your eyes, nose, and mouth if you do not have to, and without washing your hands first. Again, get vaccinated. Make sure you avoid close contact with people. Make sure you clean and disinfect your surfaces with alcohol-based or bleach-based substance, especially high traffic surfaces. For example, when I go to work, I make sure the computer, my area, is sanitized before I even sit down, because I don't know who used it before I did and how, if they were, practicing COVID-19 precautions. They should have, but I'm not 100% sure. So that's why I make sure to disinfect my area. Monitor your own health. If you have coughing or sneezing, make sure you get it taken care of. And then when you wear your mask, it doesn't matter if you don't wear the mask properly, it's not going to do its job. So you want to make sure that the mask covers your nose and your mouth, under your chin. So your nose under your chin, and it's flush against your cheeks so that no air can get inside. So the person who is walking around with their nose hanging out, they're doing themselves a great disservice because they're not protecting themselves. The person who has half of their mouth and their lip hanging out, they're not doing themselves a service. They're doing themselves a disservice, and they're not wearing the mask properly. It's not doing its job. And then you have the person who wears it on their chin to say they have a mask, but it is not doing anything for them. So you want to make sure that if you wear a mask, and in some situations, I recommend a double mask, that you, in fact, are wearing them properly. So how can you save a life? So we're going to just talk about a couple of different ways that I encourage you to research, maybe even take a class. There are a lot of free classes out there, just in case something happens that you can save a life. First of all, hands-only CPR. You can save a life. If someone in front of you becomes unconscious, they don't have a pulse, you can begin hands-only CPR and potentially save their life. No more are they doing the airway compressions. They're not doing the mouth-to-mouth resuscitation, but they are doing the hands-only CPR. What you're doing is you're actually compressing the heart. So you're helping to circulate the blood through the body when you compress and then you decompress. And you can do that until help arrives. But certainly, if there is a problem, I would hope that you would, from now, learn hands-only CPR so that you would be able to assist. It can double or even triple a victim's chance of survival. We have seen recently where basketball players, there was a gentleman who was on the court, he collapsed, and because there was a team with the medical team and there was a defibrillator on site, they were able to shock his heart and to bring his heart back into a normal rhythm. And he made it to the hospital and actually got a pacemaker or defibrillator implanted. And so that would not happen to him again. But remember, you can save a life. You can recognize a stroke, okay, using the B FAST acronym. So B, if someone is having balance issues, if you notice that their eyes, or if they have a change in vision, or you notice a difference in their eyes, if you notice that one side of their face is drooping, that could be what we call Bell's palsy, facial palsy, a quote unquote mini stroke, or it could be a real stroke. You won't be able to tell. You have to take them to the hospital. If they're weak on one side, arm or leg weakness, if they're having difficulty speaking, it's time to call 911, because time is brain and brain is time. So you have to get them to a hospital so that they can be diagnosed and potentially get a life-saving intervention. And remember, strokes can be both the clotting type or they can be the bleeding type. So if someone, for example, has an aneurysm, or if they have an enlargement of a blood vessel in their brain and it ruptures, they can have stroke-like symptoms when in fact they are bleeding into their brain. On the other hand, if someone has a stroke where it's a thrombotic event, they get a blood clot that goes to the brain, blocks an artery, and depending on where that is, you can see one of these or many other symptoms. So the important thing is to recognize it and to call 911. And the last save a life maneuver that all of you can do is the Heimlich maneuver. And that's where if someone is choking, truly choking, like they really can't breathe, you see they're not moving air, that you actually put your thumb and fist right above the navel where the sternum is, and you thrust upward, inward and upward. And what you're doing is you're using the diaphragm to create pressure that will hopefully take whatever food that is and jut it out the opposite way through their mouth. So through the motion of the Heimlich maneuver, you raise the diaphragm, you increase the pressure, and you hopefully are able to get whatever is blocking their airway out. And so that is a very important maneuver. In fact, I was just hearing today where someone was in a restaurant choking, and a passerby noticed that they were choking, and all the other 4 people that were with that person were just looking at them. But this passerby actually did the Heimlich maneuver and was able to dislodge the food that had become lodged in their trachea. And so that is the end of my presentation. I encourage you to look us up on medicalmentor.org and become part of medical mentoring in medicine. So I guess with that, I'll stop sharing and take some questions.
Thank you so much, Dr. Holden, for your time. I just wanted to let you know that after the Q&A session, we will have a wrap-up presentation, and you can definitely just leave after you're done answering the questions, since you did say that you had another meeting after this.
I do, yes. Thanks.
So with the first question, a student asks, why do minorities and women present differently than men when having a heart attack?
That's an excellent question. So, you know, the reason that we have researched is because, well, there are many reasons why. A lot of it could be access to medical care. It could be underlying diseases that the person has. Could be family history or genes. That plays a very strong role in what diseases you have. But the important thing is that not only with heart attacks, but with other diseases, with medications, for example, we realize that minorities are affected differently. And so we have to raise awareness of that so there's not a delay in the treatment of certain diseases.
Awesome, thank you for that answer. Another question we had was, is it true that the majority of cases coming into ER are stomach pain and chest pains?
Oh, it depends. It could be anything. So it depends. I mean, one of the, I guess, joys for me of emergency medicine is that I just don't know what I'm going to encounter. I don't know. I just know I'm going to be in a room, in an area, department. I don't know if I'm going, who I'm going to be working with, who's going to be on the team. I don't know what the patients are going to present with. I don't know how sick they will or will not be. But I just know that for 8, 10, or 12 hours, I am going to be in one area responsible for quite a few patients, depending on the volume.
Awesome, thank you for that. Another question we had was, what is your work-life balance as an emergency medicine physician and a professor?
Thank you. That's a great question. So the one of the great aspects of emergency medicine is that you do get a great work-life balance. When you're in the hospital, when you're on duty, yes, you are there. You cannot leave, whether that be during the day, overnight, whatever shift I happen to be working. However, when I am not there, when I'm not on shift, I am teaching, I am doing various activities, joining committees nationally that have to do with my interest, doing research. I saw there was a question about research. Yes, emergency physicians do research, whether it be research, medical research, or educational research, or social research. So yes, emergency medicine is one of the few specialties where you can pursue, and I think almost everyone in my group, they're pursuing other interests in addition to practicing emergency medicine.
Another question we had was, have you ever had a medical scribe assist you with documentation? And if so, what was it like to have a scribe?
So I will say, I wish I had a scribe. We do not have scribes in our emergency department. However, a lot of emergency departments and urgent care centers do have scribes. And I know that there are a lot of students, pre-medical students, actually serve as scribes. So that would be a great opportunity for you not only to learn the language of medicine, but also to be shadow, because you would be right there in the thick of whatever is happening while you're doing the scribing. So I encourage you to try to find those positions.
Great. So another question we had was regarding the case study that you showed, the first case study. The student is asking, in this example, should we begin the physical exam with the thorax, auscultation of the heart and breathing sounds, and then the rest of the body, or should they do the physical exam that is from the head to toes?
Okay, so remember I said it depends on the history and certain aspects you can notice from the door. So certainly the first case where the person's face was very swollen, we would get concerned about A. So our strategy is always the ABCs, right? The airway, the breathing, the circulation, disability. We saw that that patient had was concerning. Everyone agreed about that. So we were concerned about her airway. The second case, we noticed that his airway was patent, but the way he was breathing was not normal and his vital signs were affected. So we would go hone in on why is this person breathing? How can we help him to breathe better with medications and other treatments?
As a last question for us, if you had any last advice for our pre-health students here.
Yes, I would just say that, just continue to follow your dream. There are resources out there to help you. Don't be afraid to ask for help. There are plenty of people who want to help you to succeed and are here waiting for you to ask. So don't be afraid to ask for help. If you are, for example, interested in a certain topic in research, breast cancer, for example, then you can look online and you can contact someone who's doing breast cancer research, and then you can call them and say, listen, is there a way, or do you know someone that some way that I can participate in your lab or someone else's lab? I'm sure that person would be more than happy to speak with you and potentially to help you to get a position. So just ask. Do not be afraid to ask for help or to ask for more knowledge, because people are waiting for you to ask them.
Awesome. I just want to thank you once again. Thank you so much for being so elaborate on your responses and for sharing your personal history with your heart condition when you had your child. Thank you so much for sharing that information.
Thank you. It's a pleasure.
Awesome. Thank you. I'll just go ahead and let you go so you can head on to your next meeting.
Bye-bye, everyone.
Bye. Have a nice day. So for our students, I'm going to go ahead and share my screen, and we'll go ahead and finish with our wrap-up presentation. So after that amazing presentation, which is very informative, I think we all learned a lot from our speaker. If you would like to reflect and have a few questions that can prompt on your reflection, this isn't required, but it's always nice to reflect on our knowledge. We always like to encourage everyone to reflect on these 3 questions. What brought you to the session today? What are 3 major takeaways you got? And what do you want to learn more about? So this writing reflection is not required, but we do encourage you, if you plan to write it, we do encourage you to submit your writing to our website for publication, and so we can recognize your hard work and to enhance your future application. So if you plan to reflect, please let us know by submitting your application using the link in the chat. With this, you can also, apart from reflections, you can also write articles and reviews and success stories on plenty of other topics besides our live sessions. And I would like to mention once again that Pre-Health Shadowing is launching a research program that will allow students to connect with principal investigators as they conduct research in a plethora of topics and fields and locations. The program is 100% remote, and you can meet so many different people, your colleagues and your principal investigators from around the world and across the nation. So I do encourage everyone to apply if you're interested in research. We are currently looking for researchers for the summer. So if you're interested, please make sure to apply. And for more information, you can fill out the interest form set in the chat below, and we will contact you when we have everything ready so you can get started on your research. Furthermore, Pre-Health Shadowing is hosting a bingo board social media event for July. So you will be able to fill up a bingo board with each board having a specified dollar amount. So whenever someone donates, you can knock those dollar amounts out and fill out your bingo board. To participate, all you need to do is post this on your social media platforms, and you can have a group of friends to help you fill up the board. Additionally, we have partnered up with Krispy Kreme, like I said, in our startup. And with a donation of just $10, you'll be able to donate to Pre-Health Shadowing and also get a dozen donuts, which also helps us a lot. So for more information and instructions on how to donate and get your donuts, you can go ahead and click the link in the chat and sign up to donate. Lastly, it is the perfect time to exercise outdoors during the summer. So every 1 hour you exercise, you will be able to have $5 donated to you. For more information, please visit our website underneath the blog section and find more information on the PHS Pledge Drive. If you want to learn more about pre-health shadowing and get involved, you can join our student team where you can lead initiatives, lead volunteers, and collaborate with like-minded students. If you don't have much time on your hands, you can become an asynchronous volunteer, and you can do asynchronous tasks on your own time. So both of these opportunities are open to you. You can go ahead and visit our website and click the link on the chat to apply. And you can go ahead and also do the poll that was just sent out right now. All right, so once again, we are humbly asking that if you are financially able to donate, that you please consider sending a few dollars to pre-health shadowing. We are student run and it does cost a lot to keep our platform and program running. And if you are able to donate and know other people who can, please send the link, the donation link to them. And you are able to help others get the education they deserve and just keep our program running with any donation you're able to do. So we'd be grateful for anything you can do. Now for the part we've all been waiting for, we're going to learn how to take our post-shadowing assessment. So first, you're to earn a digital certificate for today's session. You're going to visit the professionals course page at prehealthshadowing.com. You can look up their name on upcoming sessions, and we'll have our session for Dr. Holden there. Next, you can take our quick 10-question multiple choice quiz. The quiz is based on the content from the session today, and you will have 30 minutes per attempt to earn a 70% or higher to get your certificate. We know that sometimes tech can be difficult, so we are going to allow 2 attempts for you to get a 70% on your quiz to earn your certificate. Due to a high influx of students going onto our website, we encourage everyone to wait at least a few minutes, 30 minutes to an hour after the session to take the quiz. Once you have passed, you can click the Finish Course button at the bottom of the professionals page and download your certificate verifying your virtual shadowing hours. And the quiz is open indefinitely, so you're able to take it tomorrow or the next day if you're not able to take it right after the session. If you happen to miss a part of the session, you want to refresh your memory for the quiz, or just want to go back because the session was so cool, you can go ahead and visit this session or other sessions at our website and our YouTube channel, Pre-Health Shadowing. And you can definitely watch the previous recordings, and you're able to take post-shadowing assessments on the previous recordings as well, since the quizzes are open indefinitely. Last but not least, be sure to catch up with us and follow us on TikTok and Instagram, and make sure to sign up for our email list. And our email list and Instagram, we send out when we're going to have our sessions and our events. So be sure to sign up for them to keep yourself updated. Thank you so much for joining us today, and please stick around if you have any questions. I'll be happy to answer them with my teammates. And if you don't have any questions, thank you so much for joining us today. Our shadowing session is officially over, and I invite you all to log off. I hope everyone has a wonderful day.